So, good morning everyone. Today I'll be discussing on management of traumatic glaucoma. So, as you all know, traumatic glaucoma is a major cause of blindness. So, before one start treating a patient with traumatic glaucoma, they have to clearly understand what is the predisposing factor for this rise in intraocular pressure. Only then the right treatment option can be chosen. So this traumatic glaucoma can happen following blunt injury or lacerating injury or chemical exposure or radiation, and also it has a varied presentation. It can happen within days to weeks or several years after injury. And here the IOP elevation, it can manifest as an acute reversible transient condition, or it can manifest as a chronic irreversible open angle glaucoma or angle closure glaucoma stage. Shihota et al., he did a detailed analysis of what are the predictive factors for developing glaucoma in patients with closed lobe injury. And his observations are advancing age, lens injury, high intraocular pressure, hyphema, increased trabecular meshwork pigmentation of more than or equal to grade 3, and angle recession of more than 180 degrees. Now comes the most challenging part, like how we record intraocular pressure in patients with distorted corneas. This happens especially in patients with penetrating or perforating injury and also in patients with severe chemical injury, where the cornea is going to be really scarred, edematous and traumatized. Here, recording intraocular pressure with Goldmann applanation tonometry is not going to be that much accurate since the corneal contact surface area is more than 3.06 mm. So we need to choose alternative methods of tonometry like rebound tonometry, transpalpable tonometer, digital tonometer or tonopen. Here the advantage of using tonopen is that the corneal contact surface area is only about 1 mm. So accuracy of recording intraocular pressure is going to be relatively a little bit greater when compared to Goldmann applanation tonometry. So few patients immediately after injury who are predisposed to develop glaucoma in future, they can manifest with very low intraocular pressure. So this could be due to either severe inflammation in the anterior chamber or due to a formation of the cyclodialysis cleft. So this is a communication between the anterior chamber and the suprachoroidal space. Eventually, these patients may end up with increase in intraocular pressure once the inflammation is controlled or with the closure of the cyclodialysis cleft. So regarding mechanism of injury, so with the interest of time, I will be discussing about three major types of injury: closed lobe, open lobe and chemical injury. So if we think of closed lobe injury, here the increase in intraocular pressure is going to be relatively greater and also it develops much earlier. And it is a medically refractory condition where the patient needs multiple surgical interventions to control the intraocular pressure. Here the possible mechanisms are angle recession, hyphema, pigment dispersion and lens injury. When we take this open lobe injury, when compared to closed lobe, here there are less chances of trabecular meshwork damage and lens injury. And here the possible mechanisms are inflammation, oppositional cynical angle closure, Gosel glaucoma and lens related mechanisms. When we take this chemical injury, here the alkali injuries are more common hazardous than acidic injury, and here the possible mechanisms are collagen shrinkage and contraction and pupillary block and damage to trabecular meshwork and collector channels. So now coming to management of traumatic glaucoma. So this includes a broad spectrum of management. It can be as simple as just eliminating the underlying cause, or it can be a challenging one where the patient may need a lot of multiple surgical interventions to control the intraocular pressure. So the treatment options available are medical management, laser peripheral iridotomy, cataract extraction, AC wash, and invasive glaucoma filtration surgeries like trabeculectomy and GDD, and non-invasive cyclodestructive procedures like micropulse and diode. So regarding medical management, several studies have clearly stated there is a good outcomes with medical management alone in more than 50 to 80% of patients. And few patients, they may need a supportive treatment with steroids and cycloplegics also. And as such, PG analogs, there is no any absolute contraindication in prescribing in some patients except for severe inflammation. Regarding trabeculectomy with antifibrotics, so as you all know, trauma and angle recession, they are independent risk factors for blood fibrosis and blood failure. So we need to consider using high dose of MMC in such patients. But we have to remember that there is a long-term risk of blood-related infection in these patients. And relative contraindication are chemical injury, and scarred conjunctiva. Regarding GDD, if the patient is having severe inflammation, angle recession, trauma-induced aphakia or pseudophakia, then they are prone to develop early blood fibrosis. So in such patients, we preferably choose RD with supramid stenting or AGV, depending upon the severity of glaucoma. And in patients with a very good visual prognosis, when the intraocular pressure is going to be really high, who are predisposed to develop lot of choroidal complications with invasive glaucoma filtering surgeries, then we may preferably do a micropulse. If the patient visual prognosis is going to be poor, then we prefer doing a diode CPC. Now, how do we deal with different clinical scenarios? First is angle recession glaucoma. As you all know, angle recession is only a pathological finding. Only about 7 to 9% of angle recession patients is going to develop glaucoma, that too several years after injury. So it is very important to annually follow up these patients if the angle recession is going to be more than 180 degrees. Regarding lens subluxation and dislocation, if the patient is going to have more than 25% of the zonular rupture, then lens subluxation may be present. If the zonular rupture is going to be relatively severe, then the patient may manifest with either anterior or posterior dislocation of lens. And UBM can be used to assess the extent of zonular damage. If there is impending or established pupillary block, then laser iridotomy is very important. If the patient is having a dislocated or a subtotal subluxated lens, then we preferably do a cataract extraction either by anterior approach or by a pars plana approach. So this is a patient with lens particle glaucoma where you could see a clearly penetrating injury of the cornea with the corresponding iris wound, and also this is a traumatic cataract with the ALC rupture with the spillover cortical matter in the anterior chamber. So this patient, initially he was managed with steroids and cycloplegics and glaucoma medications, and subsequently he underwent a cataract extraction to control intraocular pressure. So we have to remember that if a patient is having a prolonged persistent inflammation after trauma, which is not at all getting controlled with steroids and cycloplegics, then we have to rule out a retained intraocular foreign body. And in patients with hyphema, like almost 95% of traumatic hyphemas, they get settled with conservative management alone. Only 5% of traumatic hyphemas, they need an AC wash. So this AC wash is reserved for patients if the IOP is really going to be high of more than 50 mm mercury for more than 5 days, or more than 45 mm mercury for more than 1 week, or more than 35 mm mercury for more than 2 weeks. So ghost cell glaucoma, ghost cells are nothing but they are the khaki colored cells which are degenerated, depigmented RBCs, which is going to block the trabecular meshwork. So these patients may be treated either conservatively with medical management or AC wash, and few patients may need vitrectomy and trabeculectomy also. And regarding orbital hemorrhage, so orbital hemorrhage, if the orbital hemorrhage is going to be very severe, it can lead to increase in intraorbital pressure as well as increase in intraocular pressure. So these patients may need a orbital decompression procedures like lateral canthotomy with or without inferior cantholysis if the IOP is going to be more than 40 mm mercury with an RAPD with the worsening visual acuity with the appreciation of retinal arterial pulsations or intractable pain. So thank you. Thank you all for the